individual to something like this. Approaches, if you are going to perform this single stage, when is it staged? Which one to potentially consider doing first, cervical spine, cervicothoracic, or thoracolumbar. And then talk about the utility, touching upon some very limited data on outcomes for this patient population, and then talk about things to look out for, quote-unquote, complications after these operations. We'll follow that by 3 really nice cases by our 3 fellows this year, as well as my partners, Lionel Metz, Shane Birch, and Sig Irvin. So why and when? It's not a common thing that people undergo cervical to pelvis fusions, but it does happen. And the most common is on the right. It's usually secondary to revision operations after long thoracolumbar fusions that result in PJK, or vice versa, those with cervical thoracic or even cervical fusions that have the curse of DJK that end up extending all the way down to the pelvis. But there are times when patients will have a primary deformity that is both a combination of a subaxial or cervical thoracic and thoracolumbar deformity in some variety. And then there is the less common, even less common indication for tandem stenosis, and we'll show some case examples of that tonight. So just to show a couple of the x-rays to start off. So primary reasons for the concomitant cervical, cervicothoracic, thoracolumbar sagittal deformities as seen here. I think it's important to understand just at the fundamentals. We won't go into a huge amount of detail here on how to recognize these with some simple radiographic parameters. And I use T1 slope as the equator for this. Things above the equator, the T1 slope, will manifest differently radiographically, whereas those below will have different parameters. And I mainly focus on the C2 tilt in combination with the T1 slope. So those patients who have a isolated subaxial kyphosis will have a low T1 slope, and then they will have a high C2 tilt as a result of compensation to the upper cervical spine, the OC to C2. This is is in reverse to those patients who have a thoracic kyphosis or a thoracolumbar kyphosis or lumbar kyphosis, where they have a high T1 slope and their compensation is hyperextension of the subaxial cervical spine. So they'll have a low C2 tilt, and then they'll have a high T1 slope. Now, for those patients who have a combination of the two, which is a patient who may end up with a cervical to pelvis fusion, at least primarily, those have a combination of the two. So they have a high T1 slope driven by their thoracolumbar deformity, and then they'll have a high C2 tilt as a result of their compensation to the upper cervical spine. This is a very classic example of someone who would fall into this category of a concomitant deformity, a patient with ankylosing spondylitis. You see the very rigid subaxial kyphosis trying to extend his neck. You can see how large his OC to C2 angle is, and then he has the concomitant flat back deformity from both the ankylosing spondylitis, but also a L4 fracture. In addition to kyphosis, which is just a sagittal plane deformity, you can also have a combination of a cervical thoracic kyphosis plus a thoracolumbar scoliosis. And so that would be another reason why a patient may necessitate a thoracolumbar fusion in addition to a cervical fusion. And so how should these patients be addressed? First, do both need to be addressed, both the cervical thoracic and the thoracolumbar? Present a quick study looking at why that may be the case. And then if you are going to address both, is it best to do in one single stage or two? And then really, which one first? And then the other question that arises is, what's the optimal time between stages? So just briefly, in my opinion, if we were to stage this, I prefer to do the thoracolumbar first, especially if there's no cervical myelopathy or stenosis, and I'll give you a reason shortly. And then time between stages, especially with these long instrumented fusions and deformity corrections, patients need a little bit more time to recover. I'd say minimum 3 months, if not 6 months to between stages. So in terms of addressing both, why may this be necessary or important? So this is a nice study from the ISSG relatively recently, who looked at patients with and without cervical thoracic deformity in combination with the thoracolumbar deformity. And they found that those patients that had both actually had worse outcomes when the cervical deformity had not been addressed. It says here, despite correction of thoracolumbar deformity, 50% of the patients had persistent kyphosis or sagittal malalignment. And as you can see there at the bottom, those patients with persistent cervical thoracic deformity had inferior outcomes and failure to achieve MCID at 2-year follow-up, despite having similar baseline outcomes to patients without cervical deformity. So addressing both may be necessary to optimize outcomes. So in terms of staging, just a quick case example. This is a lady of mine from several years ago, had surgeries at outside hospitals from, see that front back cervical operation, as well as the L4 to 5 TLIF. Now is a combination of a coronal plane deformity, pretty decompensated to the right, as well as her Sherman's kyphosis causing a sagittal plane deformity. And this is one where felt comfortable doing it all in one stage, extending the prior instrumentation down to the pelvis. And overall, she did quite well. This is another patient from several years ago, very, very sick gentleman, Parkinson's disease, cardiac conditions. And you can see this multiplanar deformity, almost, pretzel. And we ended up doing this all in one stage, so C2 to the pelvis, and then so L3 to S1 ALIF and C2 to the pelvis. And the reason why there's only intraoperative x-rays is because he never made it out of the hospital. And the details around of which I won't share, but he, this was clearly too big of a hit. And retrospectively, I wish I had taken it in stages. And ever since this case, I have staged them. In terms of doing this in 2 stages, I do like to do the thoracolumbar first. And the reason for that is after the thoracolumbar realignment, there are relaxation of some of the compensatory mechanisms in the upper thoracic cervical spine that may give you a better impression of what the underlying cervical or cervical thoracic deformity are. So I think it's better to build a base if you can choose between the two and work your way up in terms of realigning the pelvis and the shape of the spine to the pelvis, and especially the PI magnitude. And then this is another nice study from the ISSG from 2015, almost 10 years ago, that showed something similar, that you can have improvements in the alignment of the cervical spine, which may improve your outcomes independently. And they stated this may be direct or a reciprocal effect of the underlying global deformity on regional cervical alignment. However, after they control through the magnitude of the thoracolumbar deformity, there suggests there's a direct effect of cervical alignment on health measures. So this is a lady, picture shown before, again, prior cervical spine surgery, has this multiplanar deformity in the sagittal and coronal plane, both bothered by her neck position, but also her stoop posture. The first stage, we extended her to the upper thoracic spine after doing an L3, 4, and 5-1 ALIF. And you can say, well, she has PJK. And I think that is possible, but she just has an underlying cervical thoracic deformity that we were planning on addressing in a staged fashion. So after about 6 months, she was up for another hit, and we extended her up to C2 and is now quite a happy camper. This is her pre and post. This is another patient with both a coronal plane thoracolumbar deformity, as well as the pretty significant cervical thoracic kyphosis. And again, this is one that we wanted to address in 2 stages. He had a little bit of stenosis, but no myelopathy. And he's a priest, so actually didn't want to fix his cervical spine initially because of his need to, look down. So we initially addressed the thoracolumbar spine with an L3 to S1 ALIF, upper thoracic to pelvis. And again, you may say, well, there's some PJK, but looking at a CT scan, there's no kyphosis or fracture. And this is just his pre-existing cervical deformity. So he actually waited about a year, year and a half, and then we extended him up to C2, and he's doing quite a bit better. Now, this is a gentleman who actually was sent to me for his cervical spine, chin on chest deformity. And then after looking at his just plain cervical x-ray and seeing the high T1 slope, we got a full spine x-ray. And you can see he has this very, very severe coronal plane deformity, flat back, which was burnt out osteo, or at least we thought it was. And so we decided to say, well, even though the neck is pretty significant, we're going to build from the bottom up, create a nice foundation, and that's what we did. So we planned a T10 of pelvis, some posterior column osteotomies. Initially thought we may do 3-column osteotomy, but we use a kickstand rod on the left side to help with the coronal plane. And then we were planning 3 to 6 months later to extend to C2. But interestingly, after we did the thoracolumbar surgery, his neck posture improved. And I don't exactly know why. Usually the reverse will happen if you correct the neck in some capacity. So I thought it actually may stay the way it did, but for some reason extended. And you can actually see I put these W connectors on the upper part of the thoracic spine in anticipation of needing to use those for the extension. And so far he's not ready for the cervical spine, and I'm happy to wait until he's ready. But just an interesting effect on the cervical alignment after these deformity corrections. That's where he started. So if there is the option of doing the cervical thoracic first, and I think it depends again on the presence of stenosis in the cervical spine and just their overall complaint. Now, this lady had no lower back pain, had no thoracolumbar complaints, and it was mainly her posture. Interesting, she had a C1-2 fusion, as you see there, but has a very, very significant head thrust. It's hyperextension through the upper axial spine, OC to C1. And we ended up doing the C2 down to T10 and left the thoracolumbar deformity. But what you'll see happen is that her first post-op x-ray, she actually fractured at the level below, so T11, which made her sagittal alignment worse. We tried to treat this non-operatively, sent her for some kyphoplasties at the level and level below. It helped her pain, but she had progressive decompensation of her sagittal plane. So we then extended her down the pelvis after doing an L4 to S1 ALIF. You know, and retrospectively, I probably should have done it in the reverse. It kind of went against my principles. At least now, I think this case also taught me that building from the base up is important. So overall, she's quite happy with her neck posture and her overall alignment. Other reasons from a primary standpoint to do a cervical to thoracic fusion would be for tandem stenosis. I don't think this is common, but it can happen. So this is a lady who had multi-level ossified ligamentum flavum. You can see there at C7, T1, T1, T2, and then all the way down to about T8, 9. And so the plan, and then she also has in the lumbar spine stenosis at multiple levels, L1, 2, 3, 4, and 4, 5. So in this situation, we planned on doing this in 2 stages. Again, I think especially cord level stenosis is a pretty high risk operation from a neurologic standpoint. I think doing an upfront operation to decompress everything is probably a bit too much blood loss. It may just risk a bit too much, risk for ischemia to the cord. So we decided, at least in this lady, to do it in 2 stages. And then again, it brings up the question of which one to do first and the time between stages. For these, I prefer to do and prioritize the cord over the lumbar, especially if deformity correction is not the major driver, the indication for surgery. And between stages, I would say 3 months for these and probably minimum 6 weeks, especially if the other one's causing more neurologic symptoms and disability from a neural compression standpoint. So for this lady, as I said, we did it in 2 stages, initially with C6 down to T12. Again, I knew I was coming back, so I placed a couple W connectors at the bottom there, just to make my life easier for connection. And then about 3 months later, we did an L3 to S1 ALIF and then extended her down the pelvis. Neurologically, she significantly improved. She went from a wheelchair now to walking with a cane. And overall, I think she did quite well. This is another gentleman, pretty complex history, prior isolated cervical laminectomy. As you can see there, developed cervical kyphosis, post-laminectomy kyphosis, and then has new adjacent segment stenosis at 3-4, as well as multi-level disease and stenosis into the upper thoracic spine down to about T7. And then you can see his very significant stenosis in the lumbar spine. The combination of a cervical myelopathy plus maybe even a superimposed thoracic or lumbar thoracic myelopathy and also lumbar stenosis. So this guy was debilitated in many different ways. So again, prioritized the cord and tried to fix his kyphosis. And we did C2 down to T10. Again, those connectors there as a setup. And then again, we did L3 to S1 ALIF and then extended it down. And is quite happy with his posture and overall alignment. Neurologically also, he improved significantly. So moving from primary reasons to more revision operations or revision reasons, PJK and DJK, we talked about. I think this is where alignment and getting alignment correct, as well as optimization of bone quality, is absolutely necessary. I think a lot of reasons these mechanical complications happen for these two reasons: poor alignment and poor bone quality. So this is a lady with multiple myeloma who has a lesion at C3, 4, and 5, and she has kyphosis, and she was having progressive neurologic deficit. So we ended up addressing this with a 3-level corpectomy from the front and a C2 down to T2. And these were her discharge x-rays from the hospital. These are her first post-op x-rays. You can see that she's lost her sagittal plane because of distal junctional failure. So we extended her down to T12 or so. And you can see that we tried to do our best to cement augment everything. Her sagittal plane is not great. She's still pitched forward and retroverting her pelvis. So you can tell that there's probably a lot of cantilever forces on those distal screws. And then instead of distal failure, she actually developed a L5 compression fracture from her poor bone quality. And this decomposited her sagittal plane more. And she also had stenosis associated with this. So we extended her down the pelvis. Overall, did okay. I think alignment-wise, she's respectable. Took care of her neurologic symptoms, but you can see how quickly this can really decompensate, going from an isolated cervical issue, a tumor, down to the pelvis very rapidly. This is another situation where getting the alignment correct, especially over a 20-year period. So this is a gentleman who had an L2 to L4 fusion, TLIF. You can see here, fused flat, adjacent segment at L4-5. This is probably about 15, 20 years ago. Then he underwent extension down to his pelvis with L4 to S1 ALIF. Again, the sagittal plane was not corrected ideally. He then developed stenosis at the proximal junction that starting to cause neurologic symptoms. So at this point, that's where I came in, extended him up. And the real, I think retrospectively, I probably should have realigned him at this time. So doing an L4 pedicle subtraction osteotomy, but for a variety of reasons, we didn't do that. And took care of his initial issues. Then he developed, after this, a thoracic disc herniation that required us to go higher. And then you can see the upper cervical spine. He's now has kyphosis, developed a little PJK and cervical myelopathy. So we extended him up. And again, we never corrected the bottom. And I think that was a big reason why the top kept falling apart. So how did these patients do? The x-rays are pretty staggering. And we did a multi-center study several years ago, retrospective review of patients from 2003 to 2014 with a UIV in the cervical spine and an LIV in the sacrum or pelvis. 55 patients were included with an average follow-up of 2.8 years. The most common UIV was C2 and then C7. In terms of HRQLs, you can see here from the SRS domains, there were significant improvements in all activity, pain, mental health, and the total score. And you can see here the percent that exceeded MCID in those cervical to pelvis fusions. I think the lowest was self-image and satisfaction, but activity, pain, mental health, and total improved. Now there was a subset, sub-analysis looking at the effect of UIV. So upper cervical spine UIV C1 or T2 versus those who had subaxial C3 to 5 or low subaxial C6 or C7. And interestingly, the patients fused the upper cervical spine, so C1 or C2, at final follow-up compared to the other two groups had lower SRS scores in all domains. And even though there were improvements for all groups and similar between the groups for all domains except mental health, the upper cervical spine UIV continued to have lower increases in the mental health scores. So that would argue, well, going to the middle cervical spine or low would be preferable. But we do also need to take into consideration that mid-cervical fixation, especially with subaxial lateral mass screws, may not be ideal, and it may set you up for another proximal junctional problem, as seen on the right. So some may argue, I'm not advocating for it, but you could say, well, in these types of cases, consider cervical pedicle screws, or going up to the C2, taking these data into account. Complications, pretty staggering, 71% all complications, major complications about 40%, surgical complications were at 43%, and medical complications were at 61%. 25% had pseudoarthrosis, and over 50% required some type of reoperation. I won't belabor the point of all the different complications, but just some things, tips clinically that I've observed over time, keep an eye out for. So when patients are using the upper cervical spine to compensate for their deformity, there's both the hyperextension through the OC to C2 or C to C1, but there's also a head tilt, which is C1 to C2, that people use to maintain a horizontal gaze. And we'll talk about what to potentially expect after surgery. And then things also keep in mind the CBVA angle on correcting these, and then C2 fractures, which was the penultimate PJF. So the case from fellowship, courtesy of Dr. Gupta, Manish Gupta, for providing these slides. Lady with a lot of surgery, as you can see, has a C2 down to the pelvis, and she's tilting her head because she has a kyphosis, and that's how she maintains her forward gaze. After doing a mid T4 PSO VCR, correct her alignment, but after surgery, when she stood up, her head was still tilted like that. And that's because the soft tissues, that joint contracted a little bit. That will get better over time. But if a patient says, well, my head's still tilted, and say, well, that's just a residual compensation. And then the other thing is the OC to C2. This will relax over time, and it's a nice marker of your degree of correction. So this is that lady with the C1, C2 fusion. You can see roughly I drew the OC to C2 lordosis, and then after correcting the whole sagittal plane, it relaxed quite a bit. Now, this sometimes may not correct 100%. There's a lady with a pretty significant thoracolumbar scoliosis, thoracolumbar kyphosis, and then also a subaxial issue. And we did initially upper thoracic to pelvis, and she developed PJK, or just residual cervicothoracic subaxial deformity. Was not content with her posture, so we extended her up to C2. And I think we may have overcorrected her in some ways, maybe a little bit too much lordosis through the subaxial spine. I thought that some of her residual, looking a little bit towards the sky was because of her OC to C1 not relaxing, but it looks like it's quite open. It's parallel, so I think we just overcorrected her. And you can see here, looking at the CBVA, about 10 degrees. And when I saw these x-rays and even saw her in bed, I thought, ooh, she may not be too happy with that. She liked the position of her neck, but the problem was she couldn't see the ground. And many studies have demonstrated that an ideal CBVA is better to look down, not too down, but it's definitely not ideal to be looking up because you can't see your feet and you're going to trip on curbs and miss steps, and it can cause a lot of issues. And that's exactly what happened in this situation. She fell, she sustained a dens fracture. Thankfully, it was somewhat of a simple pattern. So we treated this non-operatively and it healed, but definitely keep this in mind in terms of correction. We did a study recently, a single center study just at UCSF, looking at all our patients C2 to pelvis. And we looked at those patients who developed dens fractures versus those who didn't to determine prevalence and also look at treatment approaches. We classified the dens fracture based on 2 classification systems. And these are the data for the 6 patients who developed it. But you can see here that the time to fracture varied considerably, and the type of fractures that were sustained were quite different. There were some very simple patterns, but there was also ones type 2 and type 3s associated with pars fractures that were considerably unstable. But the common theme here was that they all happened after a fall. This wasn't just a spontaneous fracture. These all happened after traumatic falls, not because of poor alignment, just I think it speaks to the frailty of patients and their immobility from these operations. Compared to those who did not have dens fractures, there was really no significant difference in terms of comorbidities, osteoporosis, the type of surgery that was performed, et cetera. These are the table from the study. You can see here some of the complex patterns, comminuted dens fractures with pars fractures, the tip of the screws. Some of these were treated non-operatively. And you can see one patient number 5 had a pretty complex fracture that was treated non-operatively, went on to a very severe rigid torticollis. And ultimately, what we found are those patients who had complex fractures, either type 2 or 3 with associated pars fractures, almost all of them who were treated non-operatively, or actually all of them treated non-operatively, failed. So one of the take-home points for us was that these require upfront surgical intervention, while some of the simpler patterns like patient 1 and patient 3 can be treated non-operatively. So this is a 7.5% prevalence. And in addition to the treatment of these complex fractures of surgery up front, we also recommended that as all the fractures occurred secondary to mechanical fall, inpatient community measures aimed to minimize risk and prevent mechanical falls would be beneficial in this high-risk group. So in conclusion, cervical to pelvis fusions are uncommon, heterogeneous surgical approaches, and then there can be improvements in outcomes, but there are high complication rates. Dens fractures should be something that you're aware of that can happen after this, and really understanding global sagittal alignment parameters regionally and globally, as well as understanding change in compensatory mechanisms after corrections are important. So thank you. Try to leave quite a bit of time for our cases, and just for the sake of time, because these are quite complex cases, we'll jump right in. And the first one we presented by our current fellow, Abdullah Al-Shamari, and Lionel Metz will be moderating it. So Abdullah, feel free to go through it and just tell me when to go from slide to slide.
Okay, thank you. All right, so this is a case of a 62-year-old female who presented with chronic back pain and worsening kyphosis. She had the diagnosis of Sherman kyphosis. Her pain is 5 out of 10 in the upper back and 7 out of 10 in the lower back. Past medical history, she has hypertension. And social, she works as a caregiver, and she finds it difficult now to do her job. An examination, she had the kyphotic deformity in the thoracic spine and tenderness along the midline of the thoracic spine. Or her motor and sensory exam from L2 to S1 is normal. and she failed non-operative treatment. We go to the next slide, please. And those her X-ray AP and lateral showed she had 120-degree kyphotic deformity, and also she had right thoracolumbar scoliosis at the lumbar spine, and her yeah, and her parameters are normal. Next, please. So plan at that time to do a T2 to L3 posterior spine instrumented diffusion, and those are the postoperative X-ray. Her alignment was good, and she had a good clinical outcome until year after, where she presented with both neck pain and cracking, and also she had numbness in hands, and she did not have any myelopathy, or her exam was normal, as we can see here in the X-rays. And sorry, in the CT scan and MRI, she had proximal junctional failure, and she has T1-2 molesthesis and no myelopathy. So the plan was to extend her fusion to C5 and also remove the thoracic hardware because it was symptomatic at that time. So two years post-operative, she again presented to our clinic with pain in her neck, radiating down to the scapula bilaterally. Also, she has difficulty maintaining her posture standing upright, and now she's leaning more forward. And she had lower back pain and right buttock pain. Her exam's normal. And again, she failed non-operative treatment. And can see her a new X-ray on the right. She fractured through her previous hardware, and she had again proximal junctional failure. And this is a CT and MRI showed that the patient has T1-2 non-union and hardware fracture. She had the PGF, and also she has mild stenosis at T1-2 in the MRI. And distally, she has distal junctional failure. She had adjacent level disease, where you can see a vacuum disc phenomena at 3-4 and stenosis. So plan was to do a two-stage surgery. Stage one is to do a T2 VCR and revision of the fusion, and stage two to do extension of the previous fusion from L3 to pelvis, and L3-4 PTP, and L5S1 TLF. So this is intra-op pictures from stage one after the VCR. And we achieved very good. We achieved a good correction here through the VCR, and those are post-operative X-ray. Next, please. Oh, okay. Yeah, and the second stage of revision was L3-5, sorry, L3-4 PTP and L4-5 TLF with extension to the pelvis.
Right, Abdullah.
Okay, thank you.
Lionel, if you're on, and share your thoughts about
Yeah.
the case.
Yeah, thanks, Abdullah, for a great presentation. These severe Schuman's cases are challenging, particularly in adult patients. I think looking at her preoperative X-ray, if I met her, today, kind of having gone through what I went through with her, I probably would have erred on extending her into the cervical spine up front. I think one of the things that we don't appreciate with these patients, particularly with these severe Schumanns, where we stop at T2, is the entire rib cage, the thorax is pulling on T1 through the manubrium and the rigid attachment to the T1 ribs. And so if you look at these patients immediately post-op, a lot of times you'll see their sternum jutting out because of the change in angulation of the thorax, and it just is evidence that's what really kind of clued me in to the fact that the whole thorax is pulling on T1. And that's, I think, why we see such a high failure rate at T1 too. The other thing is, these patients that you can, just looking at the image on the left, you see her spine is overgrown. This is a pediatric condition where her spine has been um, uh, in this position for such a long time that the spinal column is very overgrown. And so a shortening operation, I think once it gets this severe, is probably protective in terms of PJK. So I think if I saw her again, I would plan to go into her cervical spine. I certainly don't think you need to go up to C2 for all of these cases. I think they have a nice compensatory hyperlordosis in the cervical spine, which is protective against junctional issues in the cervical spine. So you can probably start somewhere in the mid-cervical spine, and then I would plan a 3-column osteotomy to shorten her spinal column. The distal adjacent segment or subjacent segment disease, I don't think you can necessarily predict. That's just sort of the natural history of a long fusion with just 3 discs left above the sacrum. But this point, she's doing well, and it only took her 4 surgeries to get there, I guess.
Mhm.
Yeah, I guess that was going to be the question I asked, and you answered it partially, is, with enough literature or knowledge or whatever, obviously you said if you had to do it differently, you would take it up to the cervical. There's really not enough incidence in the distal to say I should take it lower. I mean,
Yeah.
as we gain more experience, we should be able to hopefully use our knowledge to create a construct that has a lesser incidence of either proximal or distal failure.
I completely agree with that. I think, if we start out C2 to pelvis on everybody, there's nowhere for them to fail. But the truth is you're over operating on the vast majority of people. So I think the biggest thing is to, lay crepe about the natural history. Obviously don't leave segments that have obvious deformity or obvious degeneration out of the construct. But I think we have to accept that we're going to have a significant revision rate on these really complex cases, or else we end up over operating on the vast majority of people. And I think there tends to be this mission creep towards over operating because we're ashamed of our failures, and we really shouldn't be. These are just complex problems that are going to have a failure rate.
Do you feel like there's a percent over under, whereas if it's 40%, we should do more. If it's 20%, we should just leave it alone and hope that the 80% doesn't happen. Is there any agreement there yet, or we're just not there yet?
I don't think there's agreement there. I think about that all the time in my pediatric practice. The scenario comes up with is a selective thoracic fusion where, I look at, a Lenke C curve, a C modifier for the lumbar curve, and say, well, this is kind of a big kid. It's probably a 30% chance they're not going to correct appropriately, and we may have to, extend them down 3 or 4 levels. And what I juxtapose that to is the consequences of fusing additional levels that I wouldn't need to fuse, I guess. And so I think most patients would accept a 30% revision rate rather than 100% chance that they're not going to be able to move from C2 to pelvis.
Mm-hmm.
And so I don't know where that kind of inflection point is or that tipping point, but maybe studies can help us figure that out. But I think it's probably an individual decision. Depends on what they like to do with their life. If they like to dance, if they like to swim, there's certain things that they're not going to be able to do 100% if we use them to C2 to pelvis.
Jens is about to wane philosophical on this. I'm curious to hear what he says.
Yeah.
First of all, a hats off to the entire group and faculty of UCSF. These are astounding cases and beautifully done and a very honest discussion. And I learned a lot already. And Lionel, great. Kudos to the T1 discussion. I'll start with a question, and I'll explain why I'm asking this question. How many of the patients that ended up with a C2 to pelvis fusion had adentitia, meaning no teeth? Many of the x-rays I saw were patients that had no teeth, and I think that there's a causal connection to this. And this is why I'm asking. I think that the spine should be considered an organ system, not just a chain of bones and cartilage and ligaments with some neural elements enclosed. This is a very comprehensive, complex, interactive organ that fulfills the strut of the entire organism that we represent. And when I look at many of these patients, they have a organ failure kind of a situation. And our attempt at trying to fix these is a reflection of the severity of the organ failure of the spine, an integrative neuromuscular structure. So I side with you fully, Lionel. We should not hang our heads low in terms of having several surgeries on these. But if we come to a better classification beyond angles of the organ failure nature and severity, maybe we can justify the magnitude of these kind of reconstructive surgeries better and also tailor our interventions a little bit better. Thanks for letting me wax philosophically. Beautiful cases.
Very nice discussion. We'll move on to our second case, and it's a case of Dr. Shane Birch's. Austin was going to present it, but I think he's still in the OR, so Asra, our other fellow, will present it. So Asra, take it away. Just let me know when to proceed.
Sorry. So I repeat again, I was mute. This is a 71-year-old male, previously underwent L4, L5 decompression fusion at another hospital, as well as C3 to C6 posterior cervical decompression and fusion. Patient presented with symptoms of neurogenic claudication involving back pain and low back and bilateral leg pain. Examination was benign. Looking at the x-rays, there's evidence of degenerative changes above and below the fusion level on the lateral view and flat back as well. Again, basically looking at the AP here shows a little bit of a degenerative scoliosis forming as well. Fast forward, this is when the patient was seen in our clinic. Again, there is evidence of degenerative changes above and below the fusion segment, as well as a mild progression of degenerative scoliosis in the lumbar spine. Overall, patient had compensated balance, but there is evidence of flat back and retroverted pelvis. CT scan shows, again, degenerative changes above and below the fusion segment with vacuum disc phenomena at multiple levels. And lumbar spine MRI, again, shows degenerative changes at multiple levels above and below the fusion level. So patient underwent L2 to S1 interbody fusion, OLIF and ALIF, and removal of previous instrumentation, and then decompression of the lumbar spine and T10 to pelvis posterior fusion. And overall alignment looked satisfactory post-operatively. Patient initially did quite well and continued to improve over the span of 1 year follow-up, to the point that a patient only was instructed to follow up as needed. And these are the x-rays over 1 year follow-up for the patient, and alignment is still maintained. Also, same thing on the AP views. So almost a little bit more than 2 years post-op, patient presented with back to our clinic with a right-sided rib pain, and X-ray was performed that shows degenerative changes at 3 levels above the construct. Non-operative management started in terms of facet injections and RFA with good improvement in pain control. And these are the CT scans. Again, we see the degenerative changes above the construct level and anterior osteophyte formation in the thoracic spine. So in terms of thoracic pain, patient had good improvement with non-operative management. Unfortunately, patient developed neck pain with some radicular pain in affecting his hands. So he was seen in an outside hospital and was diagnosed with stenosis distal to the previous cervical stenosis, mainly at C6, C7 level. So patient underwent anterior cervical decompression and fusion at C6, C7. And these are the MRIs prior to his C6, C7 ACDF that shows stenosis distal to the previous fusion level. MRI at the thoracic spine shows some degenerative changes of the disc. However, there's no obvious significant stenosis of the cord. So patient presented after a few months, again, with persistent neck pain following his ACDF. At this point, he had a significant myelopathy symptoms, bladder dysfunction, weakness in his lower extremities, ataxic gait. So patient was counseled to undergo further surgery to address his myelopathy. And these are his, yeah.
Where was the myelopathy from? Do you have a image showing
Yes.
stenosis? And by the way, the previous ACDF below the fusion, you said that there was stenosis, and I recognize that was done elsewhere.
Yeah.
Were there symptoms associated with that other than neck pain?
Neck pain and radicular arm pain.
Hi, this is Shane Birch. This is my case. So, as a great presentation, I'll just kind of fill in the blanks here. So, the reason we chose this case is the patient essentially, had done well for a few years and then developed back almost at the same time with severe cervical spinal stenosis and severe thoracolumbar spinal stenosis. So above, essentially adjacent segment disease, not really PJK, but essentially adjacent segment disease. So we had the conundrum of having severe subjacent cervical thoracic spinal stenosis and superjacent thoracic spinal stenosis from the prior imaging. And then it gets into the choice of how do you do this? Do you do the revise the cervical part first? Do you revise the thoracic part? And essentially, this guy had lost essentially ability to completely void. He couldn't stand out of a chair. He was that weak proximally. And so what we decided to do was just extend it down, revise the cervical stuff, revise the thoracolumbar fusion, decompress at the cervicothoracic junction, decompress at the thoracolumbar junction. And, it was a massive operation, did it in one stage. And I think the real interesting part here, and by no means am I patting myself in the back there, I don't want to come across that way, but what's interesting is how well some of these patients do. And Azra, I hope Austin included the outcomes in this, because you can see, here are the outcomes that I collect in clinic, and see his initial surgery. He's the type of guy where he had 10 out of 10 pain, and then at 6 weeks, boom, dropped down for several years. His pain initially went up, and then he literally drove back into clinic at 6 weeks saying, hey, I'm just on Tylenol. And he's gardening and et cetera, et cetera. So it's amazing the functional recovery these patients can get. But he does say, I feel like my head is on a swivel. Like he feels like it's on a popsicle stick. So by no means is he perfect, but amazing from where he went to where he is now. And he's like one of the happiest patients. And in choosing this case, I gave Austin two cases. I was like, do you want the disaster case or do you want the good case? And Austin picked the good case. So I'm not, it's just amazing how some of these patients do extremely well after such a big operation.
No, it's a brilliant result. I mean, considering the symptoms prior and the function post, brilliant result.
Okay.
Yeah, I don't think I'm like unique in this. I think we all share these things. Obviously, there's somewhat of a dichotomous result here, where some people do really well and some people don't do so well. But it's good to share the good in some of these cases.
Absolutely.
Okay, we have one more case, 10 more minutes, and Asra, you keep going. This is a case of Dr. Bervins.
Yes. Okay, this is a case of a 60-year-old female. She presented to us with rapidly progressive spinal deformity. Basically, her main complaints were difficulty standing upright and feeling of leaning to the right side. Her symptoms were getting worse in the last 5 years prior to presentation. She also had some lower back pain and left-sided hip pain and shoulder pain. Some of the pertinent past medical histories are that she had a worsening mitral valve prolapse. She was diagnosed with osteoporosis, and she had a peripheral neuropathy seen on EMG. Overall examination, she had some weakness in her lower extremities and some weakness distally in her upper extremities. No other findings showed on her exam. And these are her x-rays. She has sagittal and coronal malalignment. MRI of her entire spine did not show any significant stenosis. Prior to discussion of surgery, we needed to optimize her. Basically, she had 2 failed valve repair. She had to undergo a mitral valve replacement on an urgent basis. We consulted neurology just to rule out a neuromuscular etiology for her scoliosis. Paraspinal muscle EMGs did not show any denervation. The decision was made to perform muscle biopsy during the operation to rule out neuromuscular etiology. She also was started on treatment of osteoporosis. So she underwent T3 to pelvis fusion with type 2 osteotomies in lumbar and thoracic spine, and these are the results with improvement of alignment. She was doing, her exam was unchanged. She was doing quite well. Muscle biopsy showed a mitochondrial myopathy. Patient was referred to neuromuscular clinic as well as genetic testing for further management. 2 months post-op, she had improvement of her lower back and leg pain that she previously had, but then she started complaining of increasing pain in her upper thoracic spine, and she noticed some cervicothoracic kyphosis. This is the X-ray that shows not necessarily PJK, but some cervicothoracic kyphosis. CT scan didn't show any fracture at the levels above the construct. So she was treated non-operatively with cervical spine collar to keep her head up and physiotherapy. Unfortunately, she presented back 9 months later, had trouble holding her head up. And at this point, in addition to pain, she had radicular bilateral arm pain. Again, MRI of cervical and thoracic spine did not show any cord compression. So at this point, surgical management was discussed with the patient. These are her x-rays again when she showed up after 9 months. Again, cervicothoracic kyphosis is seen here. So she underwent 2-stage surgery. Stage 1 was C4 to C7 ACDF. And Stage 2, about a week later, she underwent C2 to T7 posterior spinal fusion. We did type 2 osteotomies in thoracic spine as well as T4 PSOs for correction of alignment. 7 months post-op, she only had some mild pain in her neck, but then she felt that she was leaning forward again in terms of her posture. X-ray showed that the left S2AI screw was broken, and there was some evidence of incomplete fusion at L4 to S1. So she underwent a stage revision of lumbosacral fusion, ALIF L3 to S1, and revision of fusion T12 to pelvis. 9 months post-op, she had overall improvement in her ability to walk. Basically, she was quite satisfied. Her only symptoms were overall weakness that was related to mitochondrial myopathy. Unfortunately, during this time, she started developing worsening cardiac failure, and also she was continued with neuro rehab and neuromuscular follow-up. She presented to us with progressive cervicothoracic kyphosis X-ray showed a broken rod at C7 to T1. She also had some progressive coronal deformity to the right side, but it appeared that the main bothersome point for her was the cervicothoracic region that was falling more forward. So we decided to address this area first. So she underwent revision of posterior segmental fixation from C2 to T7 with posterior-based osteotomies C7 to T1. And these are her X-rays 2 months post-op with improved alignment. Unfortunately, about 7 months post-op, she had worsening of a heart failure. She went into cardiogenic shock, and she passed away in ICU.
So this is an interesting case. I think from the start, we recognize this is a neuromuscular scoliosis. And I think we've written extensively now about recognizing the subset of patients with a atypical deformity, a rapid progression of an atypical decompensated deformity. So I think you addressed this a little bit, Astra, but she had a pretty extensive evaluation with neurology. And in fact, her case became, with her muscle biopsy, we were able to define a new isoform of mitochondrial myopathy. We did a genotyping on her, and she had a very unusual mitochondrial myopathy. The progression of her deformity is difficult. These cases are very difficult for adjacent segments. There's a lot of demand on the implants here. As somebody who's sort of progressively losing muscular control. In her case, she was actually doing as well as she's ever been in many, many years. The last time we saw her in clinic, which was about 4 months ago. And then as Astra was presenting this, we found out that we knew at that time that she was having some cardiogenic failure related to her myopathy. And unfortunately, we found out that she just passed recently. These are I think Jens's point is a very good one, that these really are multi-system organ failures, and the spine is part of that. Even before her initial surgery, she had been admitted to an ICU for a prolonged period for multi-system organ failure. So taking these on in the first place can be very challenging, and it's really a lifelong relationship with these patients. This is somebody who I knew for over 12 years.
These are really amazing cases, and the work that you guys and gals have done is incredible. But my question to you is, what is the longevity of these cases? Alekos talked about the long-term follow-up, but are these when you're fusing the entire spine with metal, at what point is it the next thing that drops, or the next screw that breaks, and the next revision that you do? And you've written a lot about optimization and trying to determine who the best patients. And I know that this is a special subgroup, and it's not like the usual deformity patients. But what can you glean about that for us?
Well, one thing, and maybe I'll start, Alekos, and I'd love to hear your take on this as well. But the question earlier about what is an optimal risk of needing revision surgery? And I think that might have been you, Scott, who said, is it 80% to 20% that you would do a bigger operation versus 60-40? And when would you do a bigger operation in order to avoid revision on a smaller operation? Well, I can tell you, we studied this with our deformity where we fixed the fractional curve. And our revision rates were very similar between doing a smaller operation and a bigger operation. So the overall revision rates were similar, but just for different reasons. For the bigger operations, there were wound infections, there were implant breakages, there was PJK. For the smaller operations, there was some adjacent segment degeneration. But I could tell you that in general, and maybe even specifically, I can't think of a single time where I started with something smaller. I said, hey, we may need to do more down the road. But I can't think of a single time where somebody said, boy, I wish we had done a bigger operation first. So I think a lot of times these C2 to pelvises, as Alekos indicated, oftentimes, unless it's a pretty severe deformity to start off with, end up being a progression. But defaulting towards a smaller operation is something that I pretty routinely recommend. Alekos, you want to add to that?
Yeah, I agree with you, Sig. My initial experience was doing something more, and I realized that patients actually would do quite well after one, and they'll tell you when they're ready for the next one. Um, Improving durability of these operations, I think we saw several examples of rod fractures. I think that using multiple rods, especially across the cervical-thoracic junction, thoracolumbar, and lumbosacral, will help make these more durable. I do think that achieving good alignment is key. But despite doing all this, I think we'll continue to these continue to be sobering cases. I think all these examples really get to Sig's point that he taught me is you never give up on a patient. Once you go down this road, you take care of them step by step, and eventually, I think you will help them.
Jens has a question.
Yeah, and we'll need to close, but this is again a fantastic topic and really good. What can we do to minimize falls in these fractures? I want to, by the way, add Shane Birch said these patients do well, and I agree. They're some of the happiest patients we have after they've gone through torment of this piecemeal here and there. When they're finally realigned and fused, like what you identified, Alekos, they're actually very happy. So what can we do to minimize that they fall? You have a program to kind of optimize their day-to-day life so that they don't break their odontoid.
Yeah, we don't have any specific program, but I think it is important to involve the geriatricians early on. I think that there should be focus on making their household relatively safe, and whether that's some assistance there. I think that getting their alignment, making sure that they're not overcorrected looking at the sky, making sure their shoes are well fitting. This is a whole other social aspect to this care that I think we are in the infancy of, but I think is a very, very important part, not only for cervical to pelvis fusions, I think it's with all of our elderly patients undergoing these operations. Many PJKs and DJKs will be after quote unquote falls, either at a rehab facility, and it may not just be equipment that's related. I do think that there is something with frailty that needs to be optimized before surgery. This is a very multifaceted area, but I think is an important one moving forward.
I agree, Alekos. I think a big part of our preoperative optimization program is looking at what's called the Risk Assessment Prediction Tool, or the RAP tool. And that's a tool that's very predictive of patients' disposition to either home or rehab after surgery. And it also gives us the opportunity to assess what patients have for resources. And there's no question that preparing these patients and their families, bed on the first floor, getting rid of the throw rugs, in some cases, even changing where people live. That's part of preparing people for this kind of surgery. And I think that's part of our obligation is making sure that families know that this is a lifestyle and lifelong change. And I've had situations where literally patients have changed where they've lived before having surgery. I think that's part of optimization.
UCSF guys, we are grateful that you share your experience and your wisdom, and thankfully there are people around like you who have the technical expertise to handle these cases. This should be like cigarette packs. There should be a warning on this. Kids don't try this at home. But thank you very much for showing this to us and the thought that goes into it. I just want to put in a quick commercial word for those of you interested in the history of medicine. Next Wednesday, Dr. Chapman and I will be talking to the Viscogliosi brothers about the introduction of disc replacement and motion preservation into the US. So if you have an hour not wanting to look at hardware, please join us next week. But this is just wonderful. And thank you for being part of our educational family. Jens, anything to add? Did I miss anyone?
I will look forward to the next San Francisco interesting case on their MIS service.
Yeah, I mean, you showed us the maximal hardware, so surely there's got to be something much smaller.
Maybe we'll come up with that one, Alekos. We might have a tough time finding some cases, but we can work on it.
We'll do our best.
Next time we'll do occiput.
Thank you, guys.
Good night, everybody.
Thanks
for joining us.
Take care.
Thanks.
Thank you. Thank you,
Dr.
Alekos.
Bervin, Dr. Bervin, this is for you.
Thank you. It looks better on you, Jack. It looks better on you. You keep it.
You can pick it up next time you come by.
See you soon.
Good night.
Bye-bye.
Yeah, good
Take
night,
care.
everybody.